Everybody, my name is Mike Willett at the Intertribal Council of Michigan's National Native Network, and I'd like to welcome everybody to the National Native Network webinar series on cancer risk reduction in Indian Country. This webinar is titled, A New Quitline Resource, American Indian Commercial Tobacco Program. This technical assistance webinar is being hosted by the National Native Network, which offers technical assistance and resources for commercial tobacco prevention and control throughout Indian Country, and the Indian Health Service Clinical Support Center. Your presenter today is Dr. Amy Lukowski, who serves as Clinical Director for Health Initiatives and Assistant Professor of Medicine in the Department of Medicine at National Jewish Health, and Assistant Professor in the Department of Psychiatry at the University of Colorado Denver School of Medicine. She is a licensed psychologist, tobacco treatment specialist, and motivational interviewing network of trainers trainer. She has expertise in working clinically with both individual patients and populations in overcoming dependence, creating health behavior change in the areas of tobacco cessation and weight management, and addressing the psychological aspects of both dependence and obesity. We are pleased to offer continuing education credits for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated 1 credit contact hour for nurses. And to obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. By the end of this webinar, participants will be able to identify the key elements of the AICTP as a means to meet the needs of the population and improve engagement of evidence-based cessation strategies. Inform state and tribal partners of the AICTP in an attempt to increase reach into AI populations through Quitline services. And finally, inform state and tribal partners of the AICTP to lessen the impact of commercial tobacco on the American Indian population. If you have any questions, please type your questions into the question box on the lower right-hand side of the screen. Questions will be answered during the last few minutes of the webinar. Thank you, and now at this time, I will throw it over to Amy Lukowski.
Good afternoon, everyone. Hope you can all hear me. I'm going to switch gears and show my screen so that everyone can see what I'm doing. So hopefully you can all see that on your screen. I want to thank the National Native Network for having me and allowing me to talk to you today about a new resource to the American Indian community, which is entitled the American Indian Commercial Tobacco Program, as Mike mentioned earlier. So I'm very privileged to be here today and talk to you about the resource. As Mike, he already went over the objectives of the webinar, so we'll go ahead and launch into who National Jewish is. I think that's really important in understanding who's providing the resource. As we think about how we're talking to communities about the resource, you know, that's always a question as to who is it that's behind this. So National Jewish Health, for those of you who don't know, is an academic medical center that really opened its doors in 1899. And some of you may remember this, but we started off as a tuberculosis hospital. And so that's when we opened our doors in 1899. The term was known as consumptives. So there were lots of consumptives in the Denver area. It was thought that the high altitude helped tuberculosis. So that's how we opened our doors. And ever since that day, our mission has been consistent and remained the same through today. It's to heal, to discover, and to educate the healthcare community and really serve our patients with quality personalized medicine. So that's what we do. We have a clinical team, we have researchers here, and our institution has about over 2,000 faculty and staff here on campus in Denver, Colorado. As we continue that mission, we started a Quitline service in 2002. So we celebrated our 10th year as a tobacco service cessation service provider in 2012. But that mission has continued through our Quitline services. And currently today, we're the largest nonprofit tobacco cessation program in the nation. So we're very proud of that work that we do, and it's something that we really work to do really quality cessation every day, delivering over the phone and via digital health to participants every day. We reached a really huge milestone, having served over 1 million participants in helping them quit. So that's a big milestone for us. I wanted to share that with you as well. So National Jewish is really something, what our mission is and what our brand is it's science transforming life. That's our tagline, if you will. But it's something we put into practice every day, and it's something that we at QuitLogics continue to do every day. So we follow the science. And when we talk about following the science, what works to really help people really quit tobacco, commercial tobacco, and really impact the overall health of a participant's life. So the public health guidelines, as published by the Clinical Health Guidelines, came out in 2000, and they did an update in 2008. And these are the guidelines that we follow. We look at tobacco dependence as a chronic disease, understanding that it takes multiple interventions. So I want you to remember, as we go through the resource, I'll come back to this science because it's really what grounds our work. We also document and identify tobacco dependence. Obviously the people who we talk to are calling us to talk about dependence, and we treat them with coaching and medication. That is the best strategy that we know to date, that the science really promotes and supports, that coaching and medication together give participants the best chance of quitting. We also know that telephone counseling is just as effective as individual treatment or group treatment. So in the clinical guidelines, they're all viewed as the same. It's all viewed as coaching and or counseling. So if you have participants who you see in your practices or see in the community, any one of those coaching or counseling mechanisms is an evidence-based treatment. So you can use the experience of the participant to really guide your recommendation in what they should try. We also know that most people who call into the Quitline are not ready to quit, and I think that's really a myth that I always like to dispel anytime I talk to a group, because we have participants who call us who are mostly on the fence about quitting. They see good things about quitting, and they also see how difficult that might be for them. And so we understand that difficulty and really having a foot in both worlds, if you will. And so we know what strategies work for that, and motivational interviewing is an evidence-based strategy that works really well to help people move forward in making a change to quit tobacco. We also follow the CDC best practices for cessation that came out in 2014, and those really are to help people, individuals, sometimes we're out in the community helping hospital-based systems or clinic-based systems really implement systems change, so everybody looking at tobacco dependence as a collective, and then expanding insurance coverage, that we know that helps, and then also supporting Quitline capacity. So I want to give you a little bit of the understanding about our standard treatment, and then we'll go from there. So our standard Quitline treatment is 5 coaching calls. We offer that in English and Spanish. We also have translation services, so anyone can call the Quitline, and we have the ability to work with translation services for those different languages. We also work with many of our states who provide quit medications, and the various states vary in what they offer participants. For example, in Montana, who is one of our clients, they give 90 days of bupropion or varenicline as an option to participants who call in and enroll in the Quitline. They also provide nicotine replacement therapy as an option to participants as well. So they provide a wide variety of quit medications. Some of our other states provide nicotine replacement therapy and do not provide quit medications. So that just varies by state. We also have the digital health, what I refer to as digital health, but that's really our technology that really supports somebody's quit. So they may be calling us on the telephone, but we'll also give them the website so that they can go there for additional information, or there's interactive pieces that they can access as well. We also allow our participants the option to enroll in text messaging. And our text messaging is something that goes out to participants, and it depends on how they have come into the program. If they've enrolled in the program and they have a quit date, those messages are tailored to their quit date. If they're a participant who has a foot in both worlds, as I described previously, those messages are more motivational, so they are more general messages. But we have a library of, I think it's over 400 messages now, so participants can, if they're having a difficult time, they can reach out, they can text a message as to how they're feeling, and they'll get a more tailored message in response to that. So there's different options available for that. We also have an email program that participants can opt into. Email allows us to provide a little bit more information than a text message, but those go out more infrequently than text messages do. We have a mobile application as well, and we have educational materials, printed educational materials, that once somebody enrolls in our program, they get a packet of print material that they can have at their fingertips. They can access that information anytime. So all of the digital health or the print materials are really offered as a support tool for participants to use how they need it. It's really designed, and really what the evidence shows for those digital pieces or the technology pieces is that it helps with engagement. And what we know is that the more somebody is engaged with our program, so we just ran some data recently, and we found that for participants who stay in the program for at least 5 calls, they have a quit rate of 50%. So the more we can keep people engaged, the more likely they are to quit and overcome their dependence. The last piece I want to show you about the standard Quitlogics program is just our quit rates. You know, lots of times I'm out in the community and people say, well, how do you do? You know, what's your program? What's the success? And this is really how we measure success. So if we look at all of our participants across the board, those are participants who call in and just get coaching. Those are participants who call in and use quit medication of some sort. For all of our participants, our quit rate is 36.5%. So that's a great number in the Quitline industry, and it's something that we're proud to say that we can report on. When we look at just coaching alone, the coaching is supported by evidence, but as I said before, coaching plus medication is the best chance of quitting. The coaching alone is 30.7%, and this is our quit rate. If we add that NRT component to it, the nicotine replacement therapy, that bumps up the number to 37%. And then we always include in this our insured population. We work with not only states across the nation, we currently serve 15 states across the country, but we also work with different health groups, insurance plans, and corporations. So we look at the insured population as well, and their quit rate is at about 41%. So if you remember, I said that the more we can keep people engaged, we can bump those numbers up to 50%. So engagement is a huge mark for us. It's something that we're working on constantly. I want to introduce you just to some names that you may come across. Obviously, you know my name today, but we also have two of our client managers who work directly with our states. They're very involved in day-to-day communication, weekly communication with our states to really ensure that we're doing all the things that each of our states and clients want us to. So the first client manager we have is Seth Skelton, and our next one is Hillary Baca. And this is a picture of one of our American Indian Commercial Tobacco Program coaches, Kim, Lorelei, Kim, she goes by Kim, Akawenzi, and Kim is somebody who we hired who started with us with the program. Our American Indian Commercial Tobacco Program launched August 1st of 2015, and Kim and Serena started in July. So they've been up with us a while. And, you know, I think both Kim and Serena, who are our coaches for this program, they're a group that I meet with every month, and this is really a process that we've been collaborative with in developing the program. We continue that collaboration in rolling out the program and continuing to make it a quality program. Kim, she's sent me this picture, and she wanted me to share this with you, and I said, Kim, you'll have to explain this to me. And she said, well, National Jewish Health is bringing good medicine to participants by the partnerships that we're making and by making the Quitline accessible to the American Indian communities. And so she said, I just think it's perfect, and I saw a picture and I wanted to share it with the group. So I think it really encapsulates what we're trying to do here at National Jewish with this program in collaboration with our partners, and we'll talk a little bit about that. I also wanted to show you Serena House, who is our other coach for this program. They're very invested in this program. You know, when they both started, I asked, you know, why they wanted to be a part of, you know, the launching of a new program, and their goals collectively were to really, they feel responsibility to heal their community, and they want to be a part of it, and they're very excited. They come to work energetic. They're always smiling and bringing great ideas. So that's our team here who's really working hard on this program. So I wanted to talk to you about really how this program came to be, because I think that's really important. And these were some of the early questions that we asked ourselves. And when we started to go out into the community, we started to ask these questions of our stakeholders, of our partners, of our key informant interviews. And the first one was the biggest question for us, is this program conceivable? We knew the level of diversity within the American Indian population was very heterogeneous, and so we thought, you know, is this program even possible? We know there's a need for it, but is it possible? We also wanted to know how the program would be received within the community. That was a huge question for us, and so that led us to really take the time. We've been developing this program for over 2 years, just in having those conversations and making sure, you know, all of the details were right. The other piece of this is, what do we call the program? You know, we heard Native American, we heard American Indian, and as we were talking with all of our partners, you know, they told us, they gave us the answers to all of our questions, and they told us that American Indians is really the preferential name that the community likes to use, so that's what we went with. And those were some of our early questions. You can see how it started to evolve. So we knew this information. As we look at the science and we look at the literature and we say, you know, who are we having an impact with and who are we not having an impact with? And we know that American Indians are more likely to smoke and have more difficulty quitting than any other racial or ethnic groups. And so there's also this other thing that's known, and that's American Indians want to quit, and that's an important factor as we think about, you know, delivering a cessation program. We want to know what the recipients, what's their motivation, what's their thought process, and there's a strong interest in quitting. So that's very exciting for me as somebody who's a tobacco treatment specialist. You know, we want participants who are interested in quitting. Those are the participants and clients that we get excited about, and we say we can make an impact with these participants. And so that was a very positive sign for us. On the other side of that, though, there's a lower quit rate and a more difficult time maintaining long-term abstinence. So we're seeing those short quit attempts and some short-term success, but maintaining that long-term abstinence, there's some difficulty with. And then National Jewish, in terms of our own data, we have observed that our own American Indian participants have lower rates of engagement and utilization of our services. And when we talk about engagement, we look at coaching calls. We look at number of orders in NRT or quit medications given the various states. And so we saw our own data mirroring what was in the literature. When we also looked at our data, we saw these numbers, and these are numbers that we don't want to see. These are numbers that are really our key indicators to really move the needle on. We would see from our American Indian group in particular, 20% dropout at intake. So if you think back to, okay, the higher level engagement somebody has, the more likely they are to quit. Well, there's 20% of people that are never getting the chance to really have that success. So that's very concerning, a very concerning number. And then 60% drop out after only one coaching call. So we're losing the majority of the population without really ever engaging with that population to give them that 50% chance of quitting. So these are really staggering numbers to us. And then only about 20% completed 3 or more coaching calls. 3 or more is really the mark that's used across the Quitline community to say that's really an effective intervention. As I said, our program is a 5-call program, so we want people to be engaged longer term, 2 5 calls to get that higher quit rate, but 3 is really the mark across the industry. So 20%. So our data told us we have to do something. We have to do something different, and we really have to look at this and really come up with some solutions that may be viable with the community. We also looked at our average number of coaching calls. So the American Indian community completed just about half, just under, a little bit over half of coaching calls per participant as compared with the standard population, the Quitline population that we see here at National Jewish. So as you can see, there was, as we started to have the conversations, there was our data that was telling us, yes, something needs to be done. But as we went out into the community, and this was the community of people doing cessation services in the community, people doing cessation programs, American Indian cessation programs in different states. There really was support that we needed better cessation programs for this population. I mean, it was clear from all of those. I don't think we had one person say, I don't think it can be done, or there's no need for it. There was a resounding, yes, this needs to be done, and let me help and have conversations about how we can do this. So as we looked at the literature, we found that there are different programs at the tribal level, at the community level, but nothing that really tackled the American Indian population as a whole, and that can really have far-reaching capabilities like a Quitline. And that's the beauty of a Quitline, right? That's why Quitlines were started, is to really have a far-reaching capability of effective-based cessation. And so as we thought about, gosh, this is something we do it well in other communities, how can this translate into the American Indian community? So the goals of our program, and this is where we started, is to create a dedicated coaching program with culturally sensitive coaching protocols to meet the needs of the community, the heterogeneous community. We want to see engagement go up. We know engagement works across Quitline data, and so we want to see that engagement go up. We also want to help our state partners and our collaborators reach the American Indian populations any way that we can do that, talking about the program, going out into the community, talking to cessation leaders or community leaders is something that we're completely committed to. But overall, we want to lessen the impact of tobacco, commercial tobacco, on this population. We know the chronic disease or tobacco-related health impacts that are impacting this population, and we want to have an impact on that. We also know that with this population and with the relationship with tobacco, we clearly understand that there is a relationship for traditional or sacred tobacco use within the community, and we honor that. We're talking about commercial tobacco products with this population, and we're also talking about, we're working with the participants to say, what is your goal with commercial tobacco? Obviously, our hope is that the world is free of commercial tobacco because of the impact of it, but we're taking what the participants' goals are as driving the intervention. So if a participant calls us and they say, gosh, I want to reduce my commercial tobacco use, then that's going to be the goal. We're not going to make quitting as the goal. We heard very clearly from our talking circle feedback that that could be a turnoff, and so our goal is to engage with participants. It's not to turn people away. So that's something that's different than our standard Quitline. So as we think about who we talk to, lots of times people are asking about that. We looked, as I said, we had great partners in Montana and Michigan. Gosh, we couldn't have done without the state partners there, tribal leaders there, to really give feedback. I mean, feedback from the start of the program all the way to feedback on some of the introduction messaging that we use when people call into the Quitline. So they were very willing to participate, to lend their advice and collaboration throughout the entire process. We also did, we have great partnerships with California Smokers Helpline, and for those of you who have heard of the Asian American Quitline, that's run out of California with the California Smokers Helpline. Shu Hong Zhu is in charge of that program, and we talked to him about how he developed that program. And so we used the different resources that we had. We work with some great partners in Arizona who have done work on the ground, who are continuing to do work on the ground in the communities, providing evidence-based treatment trainings to community members, and also working at the state level to talk about what programs they had designed. They had tried to implement a program a few years back, probably 4 or 5 years back, but they wanted to talk to us about lessons they learned and how we could take that forward with us. So those were our key informant interviews, some of them, and then we also look to the literature as well to guide us. As I said, we're based in science, so we're always following that science. So just to give you a snapshot of, as we're thinking about, who are our participants, and we had talking circle participants in Montana. We had 57 participants, as you can see, the different age groups, mostly the majority in the 36 to 55 age group, and the majority female. Almost 3/4 of our participants in Montana were female. And we had 10 different tribes participating in those talking circle formatted groups. In Michigan, we had 26 participants. Again, females are overrepresented in these talking circles. We had good participation across our older populations. As we think about Quitlines in general are really good about reaching the over 40 population. So it's not surprising for me to see those numbers. It may be surprising for some of you to see that different breakdown. The 20 to 29-year-old population is a hard population to reach, so that's another area of focus for us. In Michigan as well, we had 4 tribal affiliations, 4 tribes participating in the talking circles. So as we talked, as our community partners, actually we had community level people who already had relationships established within the community actually conducting the talking circles. So they got very honest feedback, very varied feedback, and as we collected those, we put those into the emerging themes, what came out of those conversations. And these were the things that came out of the conversations from that qualitative analysis. We also included in the qualitative analysis the key informant interviews as well, so we could see what was really bubbling to the top. And the focus group, or the talking circles, really reported that the single most important element for them for the cessation program would be to receive coaching from a native coach. And we heard that very early on. One of the questions we had to the talking circles and our key informants was, do you need to be working with somebody of the same tribe? So back to that initial question of, is this program even possible? That was really part of that question, because we heard we want to have that connection with somebody who understands us. But the overwhelming response to that was, no, it doesn't have to be somebody from my own tribe. It just has to be somebody native. And so that was very important. That's the thing that bubbled to the top the most. Let's see, the second piece, or I guess just to expand on that, it was just really important to the community to really have somebody be able to understand, to really empathize with where a participant was coming from. We also had participants from the talking circles who had used the Quitline in the past, so that was great feedback, and some who hadn't. So that was important for us. The coaching, as I said, is is something that was a key to them. For those of you who haven't had experience with the Quitline, we always try to strike this balance. We try to gather data and make it a quality experience for participants, but the intake and those gathering of data can seem very overwhelming. And so we heard that loud and clear, that when I'm ready to quit, I call the Quitline and I'm asked a lot of questions. And so we did a lot of work to really reduce the intake questions to what was really necessary. So that was where a lot of our time was spent, to really make that an engaging process from the beginning. The intake questions, there's the option for participants in this program to answer those questions at a later time, but they're not required, and so that significantly improves the engagement factor, if you will. We also wanted to incorporate into the program, as I said before, understanding that we understand the difference between commercial versus sacred or traditional tobacco use, and have that as an integral part of that. It's something that we've always known and always understood. I'm not always sure we were explicit about it, but that's very front and center for us. And then also just having those interventions that can be culturally responsive. And so it's really, again, keeping the science that we know is so effective and layering on all of the culturally appropriate interventions that we know and that we've learned about. So if you think back to the program that I described earlier, you can compare and contrast this. So for the commercial tobacco program, we offer both the phone program, what we call the phone-only program, those people who only want to utilize the telephone, or we have a combined program, which is our web phone program. So those are offered to participants in this program. As you remember, if you remember earlier, I said our coaching call program was a 5-call program. For the commercial tobacco program, we've expanded that to a 10-call program. So participants have the opportunity to work longer with a coach, with a dedicated coach, so they can work with Serena or Kim. They don't always get to work with the same coach, but they work within that small team. So they have that that dedicated feeling that so often many of our programs say, can we have a smaller group of coaches that we work with? We wanted to try that with this program, and we do that with our pregnancy program as well, which is another program that we offer. We also offer and have expanded what we call our resets, and that's really our attempt to reach participants. Participants are very hard to reach for all different reasons. Sometimes it's a scheduling reason, and we do our best to call participants back when they're available. We ask them that as part of their intake. You know, when's the best time to reach you, so that we do that in those time periods. But we've expanded that so that we can make sure we're engaging with participants. And also for referrals, we've expanded the attempt to reach people, which is also known as resets, for people who refer into this program. Those are usually providers or some kind of healthcare provider in the community. And for the commercial tobacco program, we offer nicotine replacement therapy. We offer 8 weeks of that. So that's a very a good offering for nicotine replacement therapy. They can get that in the form of the patch, the gum, or the lozenge. And we offer that in 4-week shipments. So we ship that in 2 different packages. Part of that is we want to be able to guide participants in how to use the products appropriately. We find that many people do not use nicotine replacement therapy correctly as we talk to them about their previous quit attempts or what they've attempted in the past. You'll hear them have all sorts of different ways they used it. Maybe they used it a couple hours, or maybe they used it for a week and it didn't really work. So really educating them about the appropriate use of nicotine replacement therapy. We also have offered combination therapy. If any of you are following the science, combination therapy, and what I mean by that is using a longer acting nicotine replacement therapy like a patch with a gum or lozenge, which is a short-acting therapy. Those two, the combination has really been shown to have really good effectiveness. It's really rivaling varenicline right now. So we're offering that as well for those participants who maybe need a little bit more. So that's the offering of the commercial tobacco program as compared to the standard program. As I shared with you earlier, we do work with 15 states across the country currently. The states participating in the American Indian Commercial Tobacco Program at this time are what you see on your screen: Alabama, Arkansas, Colorado, Michigan, Montana, Nevada, Pennsylvania, and Wyoming. There's lots of reasons why the full group of our states are not participating. The main reason is when we launched, we didn't have all of our states. And so those states, they were not a part of the initial discussions of launching this program. So we will be adding this program to those additional states in a short time. So this is the direct number. Now, many of you may know the 1-800-QUIT-NOW number, which is completely fine as something to, as a number to refer participants to. But this number on your screen is the direct number to our American Indian Commercial Tobacco Program. And that will get you directly to Serena or Kim. And I like to give this number out because the participant doesn't have to go through some of the initial prompting that they have to when they call into the main number. So the 855-372-0037 is something, as I said, that will get you right directly to Serena or Kim. So it's a great number to hand out if you can. If you have literature that just has 1-800-QUIT-NOW, that's completely fine. You'll get to the program as well. It just takes a few extra prompts, and sometimes prompts can upset people. For all of you consumers out there, we know what that feels like, right? So I also wanted to share with you the statistics that we have. And as I said, we launched August 1st of this year, and I pulled numbers through Friday, knowing that I was talking to you this week. So to date, we have 10 participants who have declined participation in the program. So they've been prompted. They've prompted into the program that they're interested, but they've declined to participate at intake. Those enrolled who have enrolled in the program and only had one coaching call, there's 26 who have done that. Those with 2 or more calls at this point, and those people are continuing, are 41. So we've had 77 participants call the American Indian Commercial Tobacco Program, and we've had 67 actually enroll. So 13% completed only the intake. So 20, if you remember for our data before, 20 is our benchmark. We were losing 20 before, and this is, I know, short-term data, but we're just monitoring the data as we go. And then 33% have completed an intake and 1 coaching call, and then 61% are what we would say are engaged in the program currently. So those are ongoing. So those are our numbers to date. The next steps for us are really to collaborate with our community partners to refine the program. I tell Serena and Kim every month that I meet with them, I'm learning something new every month, and it really raises questions for us as, are we doing certain pieces of the program right? Do we need to add things? Are there things that we need to think about? I'll give you a perfect example. We met last week, and Serena said to me, she was talking about a participant she was working with, and she said to me, you know, I didn't ask this participant this question because he's an elder, and I would never talk to an elder that way. And it wasn't disrespectful, but it was a very direct question. And so, again, that's just something that we have to think about. And I said, gosh, Serena, that's a really good point. You know, how do we refine this even within the protocol? And there's something, you know, that she just did on the fly because she knows that. But she modified that, and so how do we look at the program and how do we think about all of the different needs as we go through the program? For us, we're really about having a personalized experience. You know, our coaching calls are never scripted. We have some introduction scripting into the program, but as you go through the process, it's your own process. And so what you bring to the table is unique, and what the coach brings to the table is unique, and how that interaction changes because of those two different dynamics is very unique and what makes it so powerful. As Serena and Kim work with the participants, they too bring different experiences from their own background, their own life experience, everything, and so it is a unique experience for everyone. So we'll continue to collaborate not only with our coaches, but with our state partners, getting out into the community and talking to my colleagues at different levels about this program. We're standing on the mountaintops, as I say, to let everybody know this is a program that we have our heart into, and we want to lessen the impact of commercial tobacco. That's our goal, and so we're going to do everything we can to really make that happen. We are going to monitor our participants' experience, so reaching out to participants to ask them what their experience was like. That's something that's very valuable feedback to us. So as I tell Kim and Serena all the time, you know, this is a learning process for us as we go. And, you know, we're always happy to take feedback from anyone as to their experience or thoughts and ideas. That's how this program is going to continue to be delivered in a quality and effective way. So I want to provide you resources that we use. That top resource is our website that our participants can access. So that's there for you. And also other resources that we utilize and go to when we have questions and refer people to in that way. I also put on here my contact information. As I said, ideas, feedback, questions. Lots of times people have questions after the fact. Please reach out to me. I'm happy to help and answer questions in any way. And with that, I think Mike, I'm going to hand it over to Mike to see if there are any questions from participants today.
Well, thank you very much, Amy. Again, this is the time where if you have any questions, feel free to go ahead and write them down in the box on the lower right-hand side there. Also, I do want to point out that we do have handouts available, which include the resource sheet as well as Amy's PowerPoint presentation here. I'm not seeing any questions at the moment. One second here. Yeah, we do have one question here. It says, can smokeless tobacco users use the Quitline?
Absolutely, great question. We help people with any commercial tobacco dependence, so anything. E-cigarettes is a big topic for us these days. You may be getting questions in the community about that. Some people, it's a tricky product, e-cigarettes, because some people view them as a quit aid. They're not a proven quit aid, but we'll work with participants on their goals, as I said before. So yes, smokeless tobacco is definitely one of our products that we work with.
All right, fantastic. We have another question here. Were any incentives provided to get enrolled or participate in the Quitline?
In the Quitline itself, or for the talking circles?
It says, were any incentives provided to get enrollment for participation?
No. The incentive, oftentimes the quit medication is an incentive for many Quitline participants just across the board. So, lots of times our states will send out information or marketing that says, want free nicotine replacement therapy, call the Quitline. It's our job to definitely offer that, but also to educate our participants that coaching really will help boost that nicotine replacement therapy or quit medication that they're using. So that's, I guess you could see that as an incentive, but there was nothing else in addition to that.
Okay. How long has the new protocol been in place?
It started August 1st of this year, so it's just, what is that? Just a little over 3 months, 3.5 months. So we're on our way.
All right, great. One person says that they are curious as to whether or not anyone has done any work as far as signage that goes on tribally related convenience stores.
Signage for the Quitline, I'm assuming.
Yeah.
The different communities, we don't get involved in them in marketing per se. We interact with all of our different communities and states because they're also different. So we don't see a lot of that. So the answer to that is I don't know, possibly. Sometimes our states will say, hey, by the way, we put this ad up, we just wanted you to see it. So we don't really know at the local level how it's being advertised or marketed.
Okay. Are there different questions that need to be asked for smokeless tobacco users? Is it tailored differently?
Well, yes, it is tailored differently because when you answer the questions initially for the intake, that really drives what kind of product the participant is using. So that would change that piece of it. And so dependence is dependence, if you will. We look at it from a broad perspective, but smokeless tobacco users tend to have a stronger behavioral component, and so usually the focus is more tailored towards that, or with the oral piece of that. So it's definitely tailored, but again, it's what the participant's experience has been. For most people, it takes them 7 to 10 times to quit tobacco for good. And so the relapse rate is very high, and we know that. But what people have tried in the past is very valuable information and experience that the coach will talk a lot about, because oftentimes a tobacco user will say, oh, I've quit 8 times. Why can't I quit? And they'll internalize that, and they'll say, I'm such a failure, or I have a lot of shame around this, or why can't I do this? And they start to think negatively about themselves. And what we know is that 8 times that they've tried before, they've done different things, and little pieces of that have worked. Maybe it didn't help them quit for good at that time, But we really break down those processes to say, okay, tell me about the longest time that you've quit. What was that experience like? What were you doing? What was going on in your life? And so we can really conceptualize that and really start to pull out the pieces that did help them be successful for a length of time, even though it wasn't maybe what they wanted. But that's really valuable information. It's something we spend a lot of time talking about. So as you can see, every piece is different, right? Every experience somebody has, what they've tried, what they think works, what they want to try. I have a lot of participants who say, I do not want to use medication. And so we say, okay, that's great. You know, everybody has their own ideas and beliefs, and that's perfectly fine. We don't say, oh, well, you have to use this to be successful. We'll say, okay, what do you know about nicotine replacement therapy? And we'll ask them what they know, what their thoughts are about that. Are they willing to try that as opposed to a prescription medication? So there's lots of options for people. Lots of times we find that people only know about maybe one quit medication, one or two, and that's it. And they think, well, I've tried them both, so my chances are bleak for quitting for good. But there are five other medications that they can try, that they can have really good success with. So we want to talk to them about all of their options and really ask them their own thoughts and experiences about that. So you can see that can take some time. It's not a quick process. It can't be scripted, because we need to find out from them. They have very valuable information to help them be successful long-term in quitting commercial tobacco.
All right. We've got another question here. It says that the person worked with young people from their tribe, primarily teenagers, and they were wondering what curriculum you might recommend for them.
That's a great question. You know, I haven't seen a specific youth curriculum. I'm trying to think if I have a resource, but I can't remember the name of that. If that person is willing to email me, I can share. I can look through my my files and find it and share that with you.
Okay. This person says, in your listening sessions, did you hear any interest in-person session support? Were people open to calling, or is just calling a barrier?
Absolutely. I mean, we heard both. We heard people wanted Quitline representatives at the local level. And so in many communities, they do have that resource. So again, individual, group, and telephone counseling are all equally effective. They're all considered counseling and or coaching. Those two terms are used interchangeably. So what the participant wants is the most valuable guidance for treatment. If they say, I want to see somebody in person, then you work with them to get them somebody in person. If they don't have that resource, or access to care is a barrier, then the Quitline is a next best for that participant. Again, it's equal, but for that participant who wants individual in-person care, then that should be the focus of where the intervention should be, or where they should be recommended.
Okay. Do you have a plan for callers under the age of 18?
We work with callers under the age of 18. The only caveat is we cannot distribute nicotine replacement therapy to callers under 18. It's not an evidence-based strategy via FDA guidelines, so we follow that, but we work with individuals for coaching only under the age of 18.
Okay. What have you found to be the most useful resource in a person quitting tobacco?
You know, I found from my own experience that they're their best resource. But it's really educating the participants that they have the power, and that's what we do here. We really follow soundly motivational interviewing practices, and that's our belief here, that the person is the best person to help themselves. And so we send that message. We will support them through that, but we want the person to be successful for themselves, and we can support that, but they are their best resource. They can go out and find what they need, but they have to be the ones to implement it. And that's such an important message to a participant, and it's empowering. They have the resources within themselves to do that. We're just helping them really find those.
Okay. Do we know how many people are referred to the Quitline by a medical provider?
We probably do. I don't know that.
Okay.
But yeah, I mean, we have the standard, the overall Quitline. We have lots of referrals, but I couldn't tell you that breakdown just off the cuff. We could get that data, but I don't know that. We service anywhere from 7,000 calls a month up to 22,000 calls. So it's a wide variety. We are the call to action for the CDC's tip campaign. So that's why our numbers swell so much to up to 22,000. We just get a barrage of calls when those ads go out. So we get referrals from all different places, but providers are a main referral for us.
Excellent. Well, it looks like we don't have any more questions. So I believe at this point we'll go ahead and wrap things up. I want to thank everybody for attending the National Native Network webinar. And we'll be sending out a brief Survey Monkey evaluation by email this week. If you're planning to obtain CEUs for this webinar, complete the evaluation survey in its entirety within the next week. Please visit our website at keepitsacred.org to find this and other technical assistance webinars, as well as many other cancer and commercial tobacco prevention resources for tribes and tribal organizations. At this time, we'd like to wish everybody a very happy Thanksgiving, and we'll hear back from you guys soon. Thank you.